Good afternoon and welcome to this PCR live webinar about how to optimize the TAVI procedure, but also how to optimize TAVI patient's journey. My name is Stefan Tockweiler. I'm interventional cardiologist from Lucerne, Switzerland, and I'm joined here by two excellent colleagues and experts, Professor Nicholas van Mieghem from Rotterdam, the Netherlands, and Professor Dan Blackman from Leeds, United Kingdom. The objectives of these meetings are to learn about how to optimize or to further optimize the TAVI procedure, but also learn how to improve the TAVI patient's pathway, how to improve the duration of hospitalization, to shorten the duration of hospitalization, and finally, we will also look at costs associated with the procedure. I think that's going to be really interesting 60 minutes. We're ahead of us. And with increasing TAVI numbers, certainly these topics become more and more relevant as our TAVI programs have an increasing impact on hospital resources and also on healthcare budgets. And I would like to encourage you to ask questions if you have any in the chat. And with that, it's already time to introduce the first speaker. It's going to be Nicholas van Mieghem. And Nicholas, I had the pleasure to visit you in Rotterdam just a few weeks ago and to see your excellent TAVI program, high volume program. And it's going to be a pleasure to learn from you. Please show us how you optimized your TAVI procedure.
Thank you very much, Stefan, and it's a great pleasure to be part of this webinar together with you and Dan. It's mutual. I also learn a lot from your experience, so it is a joint effort as we are moving forward with our TAVI programs. So in the next slide, I will have my conflicts, and then we go to a next slide, and then we'll see what we're talking about. When we are streamlining a TAVI program, it is really important to streamline. Why? Because there is excessive burden in terms of cath lab time, monitored beds in the hospital, also echo capacity. And there is, of course, a coronary program that is running in parallel that you all need to take into account when you're developing a streamlined TAVI program. The next slide shows that we simplify and streamline in three aspects, both in procedure execution, but at the same time, we want to minimize complications, and we also want to stimulate ambulation and early discharge. Next slide. So a streamlined TAVI program really avoids redundant and excessive needless efforts. What are they? General anesthesia, a Foley catheter, balloon aortic valvuloplasty, a transesophageal echo, and a temporary pacemaker. Oftentimes, that is redundant. We no longer need it. And we want to reduce complications through also meticulous access management and also cerebral embolization if possible. In the next slide, I illustrate, and there is a little animation, that pacing on the LV wire principle. And this has been an additional step forward in the streamlining process because now we no longer have a deep venous access. And so less punctures probably also means less complications. In the next slide, you see how in the picture how it looks like. So we have a needle in the left groin that is connected with the anode, the red connector of the pacemaker, and then the cathode is connected to the skin, and then we check for sensing and also capturing. If we have that, then we're ready to go to proceed with our valve implant or balloon dilatation if needed. But we do have some exceptions, and that is when patients have a pre-existent right bundle branch block, especially if it's a long QRS duration, more than 140 milliseconds, or it is in the combination with a first-degree AV block or a bifascicular block with anterior or posterior hemi block. Next slide. And this LV pacing practice really has become beneficial, and we should not be too worried about it. And this is shown in the table where we have three cohorts. A cohort where we did LV pacing 488 patients. Then there were 139 patients who did not require any pacing at all upfront. And then we have the group of patients that had a temporary RV pacer in situ. Well, it turns out, and this is important, how often would you need a temporary pacemaker because there was no capture? Well, only 0.5%. So it's very rare. And what is the need for a temporary pacemaker if you would start without any? Well, it is only 5%. And I think that is very important. So only 5% of the patients where we started with an LV pacing strategy, we eventually inserted a temporary pacemaker. So definitely a very safe way of moving forward, as we also published earlier this year in CCI. Next slide. And obviously, after the procedure, you also need to manage conduction disturbances because they will occur in up to 30% of the patients. Most often it will be left bundle branch block, but also from Stefan, we learned that if you do an EKG and it's stable more than 2 days, then basically nothing is going to happen and the patient is at a very low risk for a delayed high-degree AV block. Other factors that we take into account is the development of a new bundle branch block, especially if it has a long QRS duration and it keeps on prolonging by daily EKGs, and also increase in PR intervals, and the combination of a left bundle branch with atrial fibrillation are potential situations that might need more monitoring. Next slide. Apart from pacing, there is also access management. The next slide shows that I think the essence of access management is ultrasound guided access, because that will really improve the quality of your arteriotomies. If we play the animation, then we see that we always will do a puncture in a cross-sectional view, in a short axis view, in order to avoid anterior wall calcium. Next slide. So now we move to how long patients will stay in a hospital after a TAVI procedure. And in principle, we only send patients to the ICU in less than 20% of the cases. That's so only 1 in 5. Other patients immediately go back to the ward after an hour in a holding area. They go back to the general ward. And then we try to discharge these patients either to their home environment or to a referring hospital. And we try to do that within 48 hours. So if we activate the animation again, then you see the results. So in the majority of cases, patients will be out of the hospital within 2 to 5 days. And these numbers are getting better and better. But so we also have our referring hospitals involved in the early discharge program, as is clearly shown here. Next slide. And by doing so, we have seen a gradual decrease of the hospital time in the EMC of the patients after a TAVI procedure. And now we are well below 5 days since the implementation of local anesthesia and also a TAVI Express program where patients are referred to the referral hospital, back to the referral hospital, or are discharged home within 48 hours. Next slide. This is the R-Express program where we also have our referring hospitals involved in the pre-procedural planning, but also in the post-procedure follow-up of the patients before they go home. By doing so, we increase the capacity in the center that is performing the TAVI procedure. Next slide. But sometimes we are not successful in discharging the patient, and predominant reasons for that are that sometimes there is a logistical issue, but oftentimes it is clinical surveillance. Clinical surveillance because there is some bleeding that is lingering, or there is a conduction disorder that we need to follow up. But it can also be like logistics or internally. We cannot do the echo within 24 hours, for instance, or sometimes the patient logistics are not organized. So the patient is not ready to go home because there is no support at home. Next slide. So Infections and delirium are other aspects that we take into account because it's often a reason why patients would stay in a hospital. The risk factors are surgical cut down, stay in the ICU, bleeding complications, and patients being overweight. We try to work on those risk factors, so percutaneous access, we try to avoid ICU, and we optimized our access management strategies, and we also stimulate ambulation. That's why a single access approach is very important. So we would prefer getting access in one groin rather than in two groins. So we use the superficial and the common femoral artery for our arterial sheets. Next slide. So delirium is reduced from 18%, almost 1 in 5 of the patients, to less than 10% in 2017, and we're now less than 5%. And contributing factors for this reduction are obviously local anesthesia, the use of simplified TAVI, but also the involvement of our geriatricians. And we also see less infections that dropped to single-digit numbers. And again, the main driver was the use of local anesthesia, no cut downs, and no use of bladder catheterization. Next slide. This is the readmission rate after TAVI with early discharge, and this is important. So we have the 3 groups, the standard of care, and then the patients who are referred to the referring hospital or the patients that are referred home. Well, if you replay the entire animation, and it becomes clear that in this time window between 2017 and 2019, the admission rate, the readmission rate was similar for the 3 strategies, and the main reason for readmission was an infection. And cardiac reasons for readmission were either heart failure or conduction disorders. But we're getting better and better in discharging our patients and identifying the patients who qualify for an early discharge. So that brings me to the final slide. And that is that Streamlined TAVI works. It is cost effective, and we are more and more mindful of our resources, and we try to involve the referring hospitals. Early discharge is feasible in selected patients. I think that in an ideal world, at least in my practice, we would aim for 50% of the patients who would be leaving the hospital within 48 hours. But it does require optimized selection strategies. Thank you for your attention, and I give the word back to Stefan.
Yes, thank you, Nicolas, for this excellent and practical presentation as well. And you not only talked about the procedure, but also about the pre and post procedural management, which is probably equally important, I would say. So then, in your experience and in the UK, are you doing that a similar way, or are there some things where you thought this is different, or this is how we further optimized everything?
Yeah, no, I mean, I think we in Leeds and most UK centres have moved a long way over the last kind of 5 years or so towards a kind of fast track and streamlined minimalist TAVI approach. I mean, there's a couple of other comments I'd make, some of which I'll mention in my talk. One is, local anaesthetic with a small amount of sedation. We have that administered by nurse specialists rather than anaesthetists. They're actually very good at that. Anaesthetists tend to issue fairly heavy duty sedation to patients and then go and sit somewhere else in the cath lab or just outside the cath lab, whereas nurse specialists stand with the patient and talk to the patient and give very little sedation or analgesia. And that's a better experience for the patient, and that, they're actually more stable and less likely to be moving around during the procedure. So that's something I think that really helps, and you can really minimize any sedation if you have someone who's a good communicator with the patient. The other thing that I wanted to ask Nicolas about actually is the secondary arterial access. So another thing we did a few years ago was move to radial for the secondary arterial access. And there's some good data actually that have come out fairly recently showing that just registry data, multi-center registry data, but comparing access site complications from the secondary access, for your marker pigtail being radial versus femoral, and actually suggesting that there may even be a mortality benefit from that, which maybe is not surprising. We know if you do 6 French radial access rather than 6 French femoral access for PCI, there is a mortality benefit. Big studies have shown that. So that's something that helps. And you can bail out femoral access complications from the wrist. It's a little bit more challenging, but and you need the right equipment. But with careful ultrasound guided puncture, as Nicholas showed, you generally, the frequency of femoral access complications is much lower. So that's another thing that we've done to kind of make the procedure more minimalist.
Yeah.
The only thing we do, which is a little, slightly more invasive, is we paste through the wire, but rather than just putting a needle in the skin, we do a ultrasound guided micropuncture of the femoral vein and leave the micropuncture wire in, just the wire, and clip onto that. And that we found that that's a little bit more reliable, but also if you do need a temporary wire, then it's much quicker to do it because you can slide a radial sheath over the micropuncture wire. But I think we're doing a lot of what Nicholas has said, and our median, we are discharging more than 50% of patients on day 1, day 0, 1 or 2. Very rarely day 0. Actually, I think that's probably to some extent a bit of a gimmick, but I think most patients can go home on day 1 or day 2, and the main issue that keeps them to day 2 rather than day 1 is a new bundle branch block.
Yes,
that's very impressive.
That's very early. So how many patients would you say do you discharge within 24 hours?
I mean, I do have these data, but not exactly to hand. I think it's about 25 to 30% on day 1, and then it's about 55 to 60% on day 1 or day 2. So that's the kind of default strategy. Some centres in the UK are even more aggressive, but I think that we do follow your algorithm from the burn data on post-procedural ECG combined with Lars Sondergaard's data, kind of supplementing that. And if they have a new conduction deficit, then we keep patients in for a minimum on telemetry for a minimum of 48 hours. I think that is the right thing to do. Even with that, I think if you break that rule, then you will get some readmissions with high-grade AV block. So that is the one thing that we do stick to. There are centres in the UK who are sending patients home even earlier with left bundles, but I think that there's a little bit of risk in that. So, 48 hours is early enough, really. Yeah.
No, I fully agree. And I think one of the messages is certainly that we can minimize or reduce the duration of hospitalization, but only to a certain extent. And we can make the procedure easier and simpler, but only to a certain extent. So we cannot compromise on patient safety. I think that's very important. So what then, if I can ask you, what do you think, if you look at, let's say, the time in the cath lab, the time in the hospital, costs, what do you think is the biggest problem? Because you recently wrote an article that many centers are having long waiting time for TAVI in the UK. What do you think is the biggest problem?
Yeah, it's a good question. I mean, we asked centres what their biggest barrier to expanding their capacity would be, because I think capacity is the issue. The biggest issue in the NHS in the UK is hospital beds. And if you look across Europe, you see that we have about half the number of beds as France, and I think a third the number of beds as Germany per head of population. So that's an issue. The second biggest issue is cath lab capacity. And the third biggest issue is CT, actually, maybe even vying with cath lab capacity, the access to cardiac CT. So that's a challenge. So I'll refer to in my talk, there's a lot of pressure actually in the UK. Numbers have gone up 20% year on year in the UK with a bit of an interruption from COVID, but there's a long way to go for us, and there's going to be, there is more support from government and the NHS for TAVI to start to move into younger patients and low and intermediate risk patients, and for the waiting times to come down substantially. And that is going to drive, I think that is going to drive an increase in capacity, but it's going to be a challenge because of those issues I mentioned. one centre in the UK recently did 6 procedures in the same cath lab in a day, but we know in our centre we do 4, we could do 5 in the cath lab, but we wouldn't have enough beds for 5. That's the biggest limiting factor.
Mm-hmm. Yeah. What about in the Netherlands, Nicolas? What would you say is the biggest limiting factor?
Well, I think Dan summarized the important ones, but I think there is one more, and that is the echo capacity, because we insist on having a discharge echo. And our echo department obviously also has to do other echoes outside of the TAVI program. So that is another limiting factor. But at the same time, I have to say that the mean age of the patients that we're treating in Rotterdam is still 80 years old. And that means that it can be challenging to get them home within 24 hours anyway. So that gives us an additional day to at least organize the echo. So I think the logistics around a TAVI program is potentially the rate limiting step.
Yeah, I mean, now on the echo we do the post TAVI echo on the table basically, and then use that as our post TAVI echo, so they don't then need to have another echo pre-discharge. Yeah. I mean, so because we have a cardiac physiologist, as part of the procedure anyway, we make sure for TAVIs that it's a cardiac physiologist who is also echo capable. And I think this comes back to what Stefan was saying. I must say, I feel myself that some people don't have even transthoracic echo in their TAVI procedures, but I do personally feel that that's something you should have, because when the blood pressure drops suddenly, which does happen, sometimes you need that immediate echo to get to know why the blood pressure's dropped. And so we have a transthoracic echo machine in the lab switched on with a cardiac physiologist who can do an echo, and then we do we don't ask them for too much on the post TAVI echo, but we ask them to take enough time to, as well as excluding complications like pericardial effusion, to report on LV function, aortic regurgitation, measure the gradients, and the basics, and in most cases that's a good enough echo to satisfy us, and then we'll have a follow-up echo 6 to 8 weeks when they come back to the outpatient clinic.
All right, so thanks for that. And I think we have time for 1 or 2 questions that are in the chat now. And I think the first one, Nicolas, you can answer. Can we reverse the red and black crocodile knobs of the pacemaker lead, or does it matter?
Yeah. No, in principle, it doesn't matter. It's just the direction of the vector, but it can work either way. And sometimes you do see better capture or better sensing when you revert the crocodile. So there is not one mandatory position of the 2 crocodiles.
All right, very good. And then there is another question. To be honest, I'm not sure if I understand it correctly. So thanks for your webinar. Do you have a target CVP measure post-TAVI? Is that central venous pressure or what is?
Yeah.
So do we measure central venous pressure?
We don't measure that. No. I mean, it's interesting in the US. I don't know whether it's still the case, but they were putting Swan Ganses in, but I think that may have been linked to reimbursement. But no, we're not measuring that. I mean, actually, we're quite enthusiastic about measuring the intracardiac hemodynamics, specifically the LVDP, which and the invasive gradients, and I think that's very helpful, especially the LVDP if you're faced with patients with some paravalvular leak. So we do measure before and after the invasive gradients, both peak and mean, and the LVDP and the AR index.
Right. Yeah, I think LVEDP and diastolic aortic pressure are certainly key before and after the procedure. So I think we can also answer more questions after your talk, Dan, and you're going to also talk about your patient pathway and also the role of the nurse coordinator.
Yeah, thanks, Stefan. So thanks. Yeah, now, as you said, I'm going to focus on the pathway, particularly the pre-procedural pathway rather than the kind of procedure and post-procedure that Nicholas addressed. And I'm going to talk about the role of the nurse specialist, which I think, is fundamental and can really enhance the quality of a TAVI program. And I'll try and convince you that that's the case. These are my potential conflicts of interest. So why do we need to do TAVI expeditiously? Well, we all know these data looking at outcomes after onset of symptoms with and without intervention, and mortality is high. The median survival is 2 years after the onset of symptoms in the context of severe aortic stenosis. But actually, the time frame we need to look at is far less than 2 years. And here are some data from a registry looking at mortality on a waiting list. So a similar kind of situation that we face in the NHS, and we've produced some similar data across the UK, showing that if patients wait, they will die while they're waiting for aortic valve intervention. And in this registry, they showed that if patients waited a month on a waiting list, either for TAVI or surgery, mortality was around 4%. If they waited 6 months, as some patients in this study were doing, then that rose to 12% in the surgical cohort, but almost a quarter of patients who waited 6 months for their TAVI died on the waiting list. So, if we think about the procedural mortality and the 30-day survival we're looking for, we're aiming for 1 to 2%. So we have a procedure here that is very safe with minimal peri-procedural mortality. And really the risk to these patients is while they're waiting to get that intervention. That's what we need to deal with. So why do patients get delayed in accessing aortic valve intervention? They may be delayed in getting to the valve center in the first place, and certainly in our healthcare scenario, patients will generally go through a peripheral hospital before they make it to the valve center, and there they may get delayed in getting to the outpatient clinic, getting the tests they need, echocardiography, invasive coronary angiography, and the CT. But they may also then face delays in the valve center. It's common for patients to be referred to the surgical team first. Even now, when they're clearly patients who are more suitable for TAVI, now the surgeons will sometimes send them back to the referring hospital, say, I think you should refer them for TAVI, and then the whole process is back to square one. They may have delays in investigations in the center, invasive angiography, CT, echo, which may not be needed, further echo. And importantly, I think, and often not commented on, and particularly relevant to the TAVI population, is delays that can follow incidental findings, things that are picked up on the CT, like lung nodules, anemia, very common in the older population. We, as like Rotterdam, still have an average age in the UK on audit data, national audit data of 80. So anemia is common. So how can we avoid these delays and streamline the pathway? Firstly, I would argue strongly that once we have a diagnosis of severe symptomatic aortic stenosis, there's no need for that patient to go to a peripheral hospital. They should be referred directly to a heart valve center if that diagnosis is made in the community, as it often is. Now, if the diagnosis is made in the peripheral hospital, that's where they get their first echo, then there should be no delay in onward referral. We don't want the peripheral hospital doing tests, waiting for the results, and then referring. They can make the arrangements for those tests, the CT, invasive angiography if required, but refer in parallel rather than in series. I think another important innovation that can streamline the pathway is to have a single referral point for severe aortic stenosis. So regardless of whether the referrer thinks the patient is going to be ending up with surgical AVR or TAVI, all referrals are made in our centre to a single referral point, and that avoids any delays in going between the services. And then those referrals are managed by a joint valve service, including a clinical nurse specialist. And that nurse specialist will look at that referral, triage the patient to the surgical clinic, the TAVI clinic, or a clinic where they can see both a surgeon and a TAVI operator if they're in that grey zone where both options may be considered. When the referral is received and triaged, the nurse can check the investigations are in place or awaited, and if not, book any outstanding necessary investigations. Next way of streamlining the pathway is to have a one-stop clinic. So when that patient comes to our outpatient clinic, if they need to see an interventional cardiologist and a surgeon, they'll see them both at the same on the same day, not necessarily not together, but one after another in the same outpatient clinic. They'll also be assessed by the clinical nurse specialist, who'll perform slightly different assessments. We generally won't repeat the echo if it was done in the last 3 months and the gradient and there were no concerns over the diagnosis, but they can, if they do need it repeating, it'll be done in the outpatient clinic. And the CT, again, if not already undertaken, will be done on the same day. The other way we've streamlined our pathway and minimized delays is by avoiding invasive chorangiography in every patient. So if we feel the patient is clearly TAVI, not surgical, and if the patient does not have chest pain or any acute coronary syndrome presentation, then we will not undertake invasive chorangiography. We will rely on the CT to exclude severe proximal coronary artery disease. If the CT does not give us an answer, then they'll get an urgent angiogram within a couple of weeks. Again, just coming back to my point about incidental findings, I think the key factor, now some of these points I'm making really speak to services where there are delays like we have faced in the UK. But I think the key point here is that if patients have incidental findings, if other diagnoses are in question, it is extremely rare that you'll find a problem that you have to fix and that's before you do the TAVI, and that would prevent you doing the TAVI, even when patients are ultimately found to have a malignancy that's picked up by chance by incidental finding on the CT or investigation of anemia. In the vast majority of patients, the aortic valve needs fixing first, then they can get on and get their cancer or other diagnosis treated. So we will pretty much ignore almost all incidental findings, or at least not allow them to deviate us from proceeding to aortic valve intervention. So finally, I think, putting all of this together, a key step that can streamline your pathways and ensure a rapid treatment of patients is to have a mandated maximum treatment time. And I'm pleased to say that after a lot of lobbying by the profession, we are now looking in the UK at a nationally mandated target of 8 weeks from diagnosis of severe aortic stenosis to definitive treatment. Now, we are not achieving this at the moment, but this is what we will be aiming to achieve. And once it's certainly in a national healthcare system, once mandated treatment targets like this come in, then hospitals will deliver the capacity to allow it to be achieved. So what about the role of the clinical nurse specialist in this pathway? I think it's interesting how this is something that varies from country to country, but in the UK, nurse specialists are fairly embedded and have add huge value to the service. And that is really at every step. So in our service, the nurse specialists take care of the triage. We don't have an interventionist or a surgeon. They have some broad guidance as to which direction to send the patients. So they'll take the referrals, they'll triage them to the surgical clinic, TAVI or joint clinic, coordinate the investigations, and then make contact as soon as that referral's seen with the patient by sending out a welcome letter, an explanation of what's going to happen next, an information booklet, a link to an information video and other resources, and perhaps most importantly in bold, contact details, so the patient will have a phone number that they can call at any time from there on for the rest of the journey. Then the nurses will be with us in the clinic, and they'll particularly focus on assessing frailty, cognitive function where relevant, and providing information to the patients, as well as the information I referred to. We have a kind of cohort of past patients who are happy to talk to prospective patients and reassure them about the process they're going to be going through. The nurses will coordinate the MDT, again, provide that continuously available contact, particularly so that if patients are deteriorating, they can phone us up and we can push them through the pathway, arrange admission if necessary. And then in the lead up to the procedure, they'll do a pre-assessment clinic, now done remotely since COVID, where patients will come in, obviously not remotely for their bloods and swab, but then they'll have a remote session, consultation, educating the patient and family. And I think importantly, and this comes back to what Nicholas was saying about 80-year-old patients planning discharge. And what we found is that patients needed to know that they might be coming home the day after the procedure or 2 days after the procedure, and they needed to have a plan as to how they were going to manage with that. Sometimes that means staying with family or having family stay with them. Then, as I said earlier, when we in our discussion, we have two of our nurse specialists who are trained to manage the patient during the procedure. And as I also said, I think from our point of view, they do a good job of this, and generally it works better, and we get through the cases quicker, and the patients are more awake, and they have a better experience and a faster recovery with the nurses looking after them during the procedure. After the procedure, the nurses take charge of looking after them, getting them mobilized on the day of the procedure, and seeing them each day until discharge, organizing rehabilitation, arranging blood tests and primary care in the community if they're discharged on the same day. Otherwise, they just have one blood test the day after the procedure, and organizing follow-up. And then the nurses will do an early telephone call to check the patients are okay, especially if they've been discharged on the same day, which is rare for us, or day one, which is more common. Then they will see them in the clinic. They don't see us, and assess symptoms and quality of life. Now, again, with the post-discharge echo, that will, if we're happy with that, that may be a telephone consultation, and then they'll plan long-term follow-up. They have a wider role apart from the pathway, and I think really that's all about communication. So we have our nurses communicate regularly with our referrers to make sure they're up to speed on what we want, what we should be doing. And they've gone out to the peripheral hospitals to talk to the referrers, and we have a regional conference, which we've held every kind of few years, to update referrers on our program. They'll communicate with the patients. We have an annual patient engagement meeting where we get feedback from patients, and we build this contact group of patients who are a really valuable resource for prospective patients to talk to. They take on the very challenging job. We delegated this with pleasure to the nurse specialists of communicating with the cardiac surgeons. But actually, in all seriousness, I think having a kind of someone who's seen as a neutral a force, a bit of a Switzerland maybe, Stefan, in this meeting of cardiac surgeons and interventional cardiologists, works really well, and we have one of our nurse specialists who was a cardiac surgical ICU nurse before coming to us. So they are, we see them as specialists for the surgeons and for us. It's a joint valve service. And then finally, they will communicate with the research team, which helps with coordination of studies and recruitment. So these are our three nurse specialists in Leeds, and you can see that they're friendly and approachable, much more approachable than I am or any of my colleagues. So in conclusion, I think hopefully I've made the case that rapid diagnosis and treatment is vital, and that we need to streamline care pathways, and we need to be targeting rapid diagnosis to treatment times and implementing those across national healthcare systems. And I'd strongly encourage you, if you don't have TAVI nurse specialists, to get some as soon as you can. They really make a huge difference. And we started off with industry support to get nurse specialists, and then it became rapidly obvious how fundamental they are. And they actually are cheap. Having a nurse doing your sedation is a lot cheaper than an anaesthetist and an anaesthetic assistant. Having a nurse doing your clinics is a lot cheaper than having a consultant. So they're cost effective, as well as adding huge quality. Thanks for your attention.
All right. Thank you very much for, again, this very clear and practical presentation. There are a lot of questions actually in the chat, which is great. I just want to ask one question about the angiogram, because this is not the first time I hear it, that there appears to be a trend to skip the pre-TAVI angiogram. And so my question is, how does this affect the heart team discussion if you have a patient that may be a candidate for both open and transcatheter valve replacement? And how is your algorithm? Like, when do you plan an angiogram, and when do you first only do a CT and then maybe plan an angiogram?
Yeah, these are good questions. I mean, it feels like a big step, not doing routine invasive coronary angiography, but once you do it, you don't miss it. It's rare that you're finding that you're having to follow up with angiography. Our algorithm is that if we think the patient may be a surgical candidate, then we ask for an invasive coronary angiogram, because the surgeons are not prepared to let go of that. But I think that will change. I think the CT adds up probably I think the surgeons will come around to realizing that a good CT will actually give them more information than an invasive coronary angiography, because they're getting a really detailed assessment of the aorta and the valve that they're not getting from an invasive coronary angiogram. At the moment, if we think there's a surgical candidate, and in our current setup, we say if they're less than 75 without other major comorbidities, then they will be considered for surgery, and they will therefore require an invasive coronary angiogram. If they're 75 or older, or they're not, they're not a surgical candidate for other reasons like previous surgery, then we don't ask for an invasive coronary angiogram unless they've got symptoms of angina. So if they have symptoms of angina, or they've had a presentation with acute coronary syndrome, then they get an invasive coronary angiogram. And then we end up, of course, with the patients, and it's fairly frequent where we look at the CT, and the CT in our service is a TAVI CT. It's not the same as a CT coronary angiogram that's done for investigation of chest pain. So you will have a reasonable proportion of patients where detailed assessment of the coronary arteries is challenging, especially in this population where there's frequently significant coronary calcification. And then you have to make a judgment, and in some of those patients you will need to do an invasive coronary angiogram, and then the priority is to do it urgently. So because we don't want to add delay because we haven't done the coronary angiogram and now they need one. So if we analyze the CT and they need it, and we need an invasive coronary angiogram, then we will get that done within 2 weeks. That's our current process, but that is a minority. I think because let's not forget, there's no indication for revascularization in the absence of symptoms, and that's what drives our algorithm. We only have the data. We have a week. We have the activation trial, which showed no benefit from PCI in patients with incidental coronary artery lesions, but it's rare. And actually today we did a patient just before I came onto the webinar in whom the CT showed suggestion of severe proximal LAD disease, and we did an invasive coronary angiogram and it showed severe proximal LAD disease, but the patient had no angina, critical aortic stenosis. So we elected to go ahead and do the TAVI with a valve that preserved coronary access, optimally preserved coronary access, and then we'll reassess the patient's symptoms and if necessary do PCI following the TAVI. So even in a case like that where we found a suggestion of disease on the CT, did an invasive angiogram, we still didn't revascularize the patient prior to TAVI.
Mm-hmm. Yeah, so very good point. I think it's going to be an interesting topic to follow during the next years. But as you point out, the CT is usually systolic triggered and there is no vasodilators given. So it's not the same quality as a coronary CT. Assess the coronaries. Maybe quickly, Nicholas, are you doing CTs in all, or 90% or 50%? Sorry,
yeah,
coronary angiograms, of course.
So obviously,
are
CT
you doing
in
an invasive angiography in all patients or only in a fraction?
No, we do it in all the patients because I think it's a strong opinion to not do systematic invasive angiography. We're not ready for that at this point. And the reason is that I believe that symptoms are very misleading in these elderly patients. But at the same time, I do acknowledge that complete revascularization or revascularization per se is not mandatory for at least short-term outcome in octogenarians that we're treating these days. But there are also anecdotes of patients with significant coronary artery disease where you implant the valve, and because of the valve implant, they become hemodynamically unstable, and then significant coronary artery disease may definitely affect the outcome. So I still find it a little bit awkward to treat the valve and leave coronaries untouched, to be honest.
No, I agree. We also do still an angiogram, not in all, but in almost all patients, unless we have a really high quality CT where we see almost no calcification. So this leads us to the next. Sorry, yeah, please.
Oh, no, I was just going to say that there's an EAPCI experts consensus statement on management of coronary artery disease in patients undergoing TAVI. That's Nicholas was also involved in. I suspect you were as well, Stefan. There are a lot of people involved, but that is, that as it stands, it will come out later this year, is still recommending invasive coronary angiography as a default. I should say that, although in the text there is discussion about the potential for relying on CT coronary angiography, and obviously the quality of CT coronary angiography will improve even in these TAVI patients, as the years go by.
Yes, we need more data. The activation trial is a very small trial, certainly not powered for endpoints other than bleeding. But there is an interesting question. So if you, maybe Nicholas, if you do a PCI, do you do it before or during TAVI or after TAVI?
Yeah, so we try to do a concomitant PCI TAVI procedure. So we will do the PCI first and then the TAVI in the same procedure. The exception would be if it's really advanced complex coronary artery disease that we would anticipate a lesion modification with atherectomy, then we would have a staged intervention. We are involved in a randomized control trial, that is the TAVI PCI study that is currently enrolling patients, where patients with significant coronary artery disease are randomized to the PCI before the TAVI versus after the TAVI. And so I think the optimal strategy is not determined yet, although I think from intuitively, I would say if there is some kind of framework in front of the coronaries, that might not make your PCI procedure easier. So that's why I would, at least today, recommend to do the PCI before the valve implant, despite the fact that we now have commissural alignment and other techniques to improve coronary access.
Very good. And then another question about the wire pacing. There seems to be a lot of interest in that. Is there any difference between different wires in terms of capture?
Not that I'm aware of. So I've been using this LV pacing with a Safari wire, with the former Confida wire that we no longer have, and with an Amplat Super Stiff, and also with a Lunderquist and a backup wire. So I used all those wires, and I don't see any difference, and there's no need to scrape, to damage the wire to get better contact or anything. I think an important aspect is that you do have your delivery system on top of the wire to have good capture and sensing. So if you would then end up with a total AV block with a poor escape rhythm, then basically you would leave the delivery system in the descending aorta, and then you would get access, venous access, and insert a temporary pacer before you take out the delivery catheter.
All right, very good. So there is more questions. I would suggest that I briefly show the cost data, and then it's only going to be 4 or 5 minutes, and then we have some more time to answer questions from the chat. So if I can have the slides. All right, very good. These are my disclosures. So we have talked now about these principles of lean TAVI, and I just summarized a few of them. So we currently do TAVI without any anesthesia, so absolutely no sedation, just a little bit of fentanyl, analgesic, and there isn't even an anesthetist or an anesthesia nurse in the room. And then we monitor the patient outside the lab, as we have previously heard, so we don't need coronary care unit, no intermediate care, no intensive care. This also enables same-day admission. The patient comes usually to the hospital at 7 in the morning fasting, and then is ideally discharged after 2 nights in the hospital, 48 hours after procedure. And what is very important when we established our lean program was to have the colleagues from the intensive care unit and also anesthetists in the boat. And because we can still have complications, of course, there can still be problems. Sometimes the patient does need ICU, sometimes the patient does need anesthesia, and therefore it's important to include them in the protocol, in the SOP. And then, of course, if you change your pathway, I think it's always good to monitor outcomes of your program and to recognize if you have any problems with patient safety, to recognize that as early as possible. This is how we changed patient transport routes or patient transport. So you can see here graphically displayed where the patient actually is during the TAVI procedure. And in red, you can see our standard minimalist TAVI program, and in blue, you would see the lean TAVI program with the same day admission. And you already just visually, you can see how much easier the lean TAVI program is. There is much less patient waiting time and much less patient transport in the hospital. And we also were able to reduce the duration of hospitalization from 6 to 3 days. I think that's about what you have in Rotterdam as well, maybe even a bit more still than what you have in the UK with optimized programs. And I show you now, the next slide is the cost slide, but I want to emphasize that our intention was never, the primary intention was not to reduce costs. A reduction in costs followed an optimized procedure and an optimized patient pathway in the hospital. But here you can see the costs in euro. This is a propensity matched analysis comparing patients before the introduction of the lean TAVI program, which was introduced 2.5 years ago, and after introduction of the lean TAVI program in blue. And you can see the total costs were reduced by 18%. And on the left side, you can see the material, which pretty much was unchanged. But what we reduced was really the internal costs. The internal costs were reduced by about 40%. And you can see that the reduction took place in pretty much all the categories involved here. So physician fees was reduced, nursing fees were reduced. Of course, ICU and intermediate care was pretty much reduced to zero. And also anesthesia, because we don't need anesthetists in almost all cases now. And this sums up to this total cost reduction of 18%. But I would also like to point out, if you look at the total costs and at the costs for materials, because it's such a lean program, the costs for materials are very close to the total costs now. So if we now want to further reduce the costs of the program, we certainly also have to aim for lower implant costs and lower costs for materials. So we have reached a point where we can still tweak a little bit our internal pathways, but it will not result in a significant cost reduction anymore. So that would be my slides. I don't know if you have a similar experience or if you have comments to these cost data. Dan, if you see that.
Yeah, I mean, I must say we haven't looked at the costs in that detail, in the same detail as that, but I think there's no doubt that a minimalist approach, such as the one we're all employing, does save money. And I think there's some obvious things you can point to, such as bed stays, and we admit patients on the day of the procedure, and that saves one night in bed, which is a cost and a restriction on capacity, as I said earlier, and then not having anesthesia is a big saving. And certainly, I mean, it's a long time since patients went to ICU, but even we have level 2, which is between a normal ward and ICU. Patients don't go there either, and that's a different cost for staying overnight. So we definitely save money. And like you, we're down to the valve costs, and that's where nationally we're working at trying to drive down costs through national procurement processes in the UK.
Mm. Something similar is happening here, and I must say that the cost effectiveness data that we have now is desperately outdated. I think what you are showing is real life, and we are definitely reducing the overall cost of a TAVI journey, if you will, by 20%. I can really understand that, because the ICU is a high cost. Also, the involvement of multiple specialists is also adding to the cost. If you can reduce that, if you can limit that, then yeah, it's inevitable that the overall price of a TAVI procedure is going down. And I think we need to update these cost effectiveness analyses for surgery and for TAVI. And then I think the cost aspect will no longer be an argument to reduce or limit adoption of TAVI in our practice.
Yes, yeah, that's a very good point, and that's also something we're discussing right now in Switzerland, because the reimbursement for a TAVI procedure is still higher than for surgical aortic valve replacement today. So I think we have one, we're very soon is 1 hour over, very quick, very interesting. We have one question. I would like to summarize a few of these questions now. And they were, is there any specific management after TAVI, immediately after TAVI, in terms of fluid management and medication? There were several people asking this.
It's a good question. So I think early discharge, the early discharge starts, as I'm sure you'll agree, with the patient immediately after the procedure. So, and the first step is have the patient on a normal ward. When they get to the coronary care unit, as we call it, where we manage, for example, our primary PCI patients, they lie in bed. They look like someone who needs to stay in bed and stay in hospital. If they go to our kind of Monday to Saturday cath lab ward, then they look like a different patient. Then you get the patient sitting out of bed early, 4 to 6 hours after the procedure. But to come to the question, another thing that makes a difference is not giving any fluid. So we used to routinely give patients intravenous fluids before and after the procedure, and now we've abandoned that. You know, the patients can drink clear fluids until 2 hours before the procedure. And then only if they have a significant reduction in their EGFR do we pre-hydrate and post-hydrate the patients. But it's another thing, you know, if they go back to the ward with no lines in, you know, because they with no temporary wire in and with no fluids running through a drip even, then that'll help you with early discharge. So we don't give any fluids. In terms of drugs, we give single antiplatelet therapy to patients unless there's an indication for anticoagulation, and if there is, then we give just the anticoagulant, the DOAC, with no additional antiplatelet agent, and I think that's in line with kind of recent European guidance.
I think an important thing to monitor is and we discussed it earlier, is the left ventricular end diastolic pressure. If it's very low, then it does make sense to give some fluids in order to minimize the risk for acute kidney injury, contrast-induced kidney injury. So, and I must say, in a majority of patients, there will not be any IV infusion happening. But if there is very low LVDP, then we might consider it, especially in these very elderly patients. Otherwise, we encourage the patients to drink.
Yeah, fully agree. And also to prevent vagal reactions, because if the patient is like the third patient in the morning, they haven't eaten and drink for hours, and then sometimes they really have low filling pressures. And if you have vagal reaction due to compression in the groin or so, it can be quite severe. Also, from my side, I think it's very important not to restart the negative thrombotrophic drugs too early. So that's all the drugs that slow the AV conduction, like beta blockers, verapamil, digoxin, or amiodarone. And we usually stop these for a few days unless the patient is in tachycardic AFib, which already shows very good AV conduction anyway. All right, so I think we have 1 minute left. I think it was a really great meeting. I also learned a lot. I hope you learned a lot as well. We have seen that there is room to improve our TAVI procedure, but also room to improve the peri-procedural management. I think there are some things that are already quite established, and I think where we have a consensus, like there is no need for sedation during the procedure. You have to try it. If you do still sedate, try it without. You will be surprised how well it works. There is no need to put every patient on ICU. We can aim for early discharge. And there is some very interesting topics like skipping the pre-procedural angiography, where we probably need more data and more experience. But overall, I think we learned a lot, and I would like to thank you for your attention, and I would like to wish you a good evening and hopefully see you in Paris very soon. Thank you very much.